First, I'd like to congratulate the Egyptian Society of Hypertension for this elegant and highly scientific meeting and accepting my apology because I made a lot of changes. I'm sorry, but I should to leave for some urgent thing, but I'm very, very careful for presenting my subject. I think it is a tough subject, which was selected and informed to me by Professor Abdel Ghani, because I couldn't find a lot of data in this subject, the management of hypertension in presence of orthostatic hypotension. And I was astonished when I tried to go through it. I was astonished by the data which is found, and all of us, I think, made the same mistake every time. The first things which is amazing to me, the prevalence of orthostatic hypotension in presence of hypertension. It is around 10%, and in some literature, 30%. It is more prevalent in old age, more prevalent in female, more prevalent with a lot of comorbidities and some medication. We all underestimated this problem because actually we didn't screen our patient for this problem. And many times the patient comes to you and you measure his blood pressure and you found his blood pressure is okay, but you didn't put in your mind is something else. There is a symptom all the time. The patient said that I have headache, I'm dizzy. Because usually you take the blood pressure during the lying down or even sitting position and not a standing position. So most of us didn't search for this problem, except when the patient said that I collapsed, I fall down. The importance, it is usually associated by a major problem related to cerebrovascular problem and cardiovascular problem, like syncope, fall down, trauma, dementia, stroke, and even death. Individual with uncontrolled hypertension, and this to me is amazing. The uncontrolled hypertension, the incidence of orthostatic hypotension is more in those groups. Hypertensive medication are commonly a problem because actually when you found your patient, if you found a orthostatic hypotension, the first things you can do, you undergrade and de-escalate the medication to counteract this. And by this, you actually facilitate the end organ damage because you didn't solve the problem of supine hypertension and non-dipping during sleep. And most of us fall in the same mistake. The definition, it is sudden drop in the pressure, 20 in systole and 10 in diastole or more in patient who is known to be hypertensive. And the patient usually symptomatic, there is a fall down, there is a syncope or dizziness. It causes a lot of causes. The most important cause, the first and second and third and fourth, the medication of the patient. Whatever the medication is, a cardiovascular medication, antihypertensive medication, or a psychotic medication. Aging is a problem, and it is a problem all over the world, actually, because most of our patients now is elderly with multiple comorbidities. Dehydration is a big problem, especially in our countries, because we have a hot weather, not all the area containing air condition. Prolonged bed rest, a lot of heart problem like cardiac valve problem, diabetes, neurological problem like Parkinsonism, Addison disease, and the other things, it is related to genetic factor. You can find that this problem in families. There is a lot of families which presenting by hypotension, and at the same time with orthostatic hypotension, you find in the organ damage there is LVH, and most of the time you are searching why there is LVH in the patient or why there is a grade of nephrosis. This is the, it may be idiopathic, hypovolemia, drug, hypopituitarism, autonomic neuropathy, and the marathon runner. El pathophysiology is a lot. Normally, when we are standing up, according to the gravity, we should have a pooling of the blood volume to the periphery. This is counteracted when the baroreceptor is functioned by appropriate way, when you have a good leg muscle and good tone in your leg. This prevents the sensation of the syncope and the stimulation of reduction of the venous return by stimulation of the baroreceptor, which help to stimulate the brain for catecholamine secretion and causing a vasoconstriction and increasing the venous return. This is the major problem, screening. You couldn't diagnose without you are searching. You should to have the doubt. There is a problem and I'm searching for it. I couldn't find any literature for screening of this problem in those group. So it started by, as usual, medical history, proper listen to the patient and his complaint. Don't even, the pressure is okay, why he is complaining? Maybe for any other reason. You should to search. The second, physical examination. You should to search for the autonomic neuropathy, which is maybe started by peripheral neuropathy in diabetic. We should to measure the blood pressure properly in different position, in recumbent position, in sitting position, and in standing position. For sure, a tilting table test will active a standard standing test is very important and crucial for diagnosis of posture hypotension, but the tilting table and 24 ambulatory blood pressure can diagnose by appropriate ways the supine hypertension. The issue is the treatment goal. This is the difficult scenario. You should to know that you have two different entities. You have hypertension in some time and hypotension and orthostatic hypotension in other time, and you should to treat this and that. And put in consideration, when you prevent the highly elevated and the high uncontrolled hypertension, by the same time you can control the orthostatic hypotension. So you should to make a balance between the two problems, and your target is to limit the symptom and prevent the end-organ damage. Improving the quality of life by decreasing the risk from fall down and controlling the supine hypertension to avoid the risk and end-organ damage, and search for the available treatment option. التريتمنت اوفر فيو كده بشكل عام. We should to treat the hypertension and we should to treat the underlying condition. So you have many tasks you should to do. First, you should to search what I can prevent. You should to prevent the causes and the medication causing posture hypotension, and at the same time you should to prevent and remove the medication or underlying condition which make the control of hypertension difficult. Patient should be discussed for the treatment, because sometimes the patient has a lot of dreams. You will not solve the problem completely. You need to just improve the quality of life, reduce the symptomatology, and at the same time prevent end organ damage. Just you should to control his symptom. All the therapy should be discussed by very detailed with the patient, and reduction of antihypertensive drug to reduce orthostatic hypotension. You should know that it can increase the incidence of, if you reduce the drug, you will increase the incidence of posture hypotension from 5 to 19. So the problem is not to reduce the drug. The problem is to reduce appropriate therapy. We have 3 evidence on the 3 trials which I found during my search, according to 2019, and they searching in the diabetic patient, because the diabetic patient has a lot of autonomic neuropathy and they have this problem, and they found that there is no significant change in posture hypotension when we control properly the hypertension. The second is a SPRINT 2020, and it is a systolic blood pressure intervention trial. It was a randomized trial, and they found that the posture hypotension didn't increase when you reduce the blood pressure below 120 or 140. So it makes no change in the increasing the incidence of hypotension. And they found that in 2021, in meta-analysis by 9 international trials, that intensive blood pressure lowering treatment actually doesn't affect a lot the posture hypotension. التريتمنت goal بتاعنا to limit due to a limiting data suggesting the angiotensin receptor and the calcium channel blocker to be preferred as antihypertensive measurements. For those cases, we haven't enough data. The data is very limited, but patients with isolated supine hypertension can be treated with a bedtime doses and short-acting drug. And this solves a lot of problems, as we mentioned, despite the timing of the antihypertensive, according to guideline, doesn't make change if it is taken morning or night, but in supine hypertension, short-acting drug to cover the night time is very important to reduce the end organ damage. And the orthostatic hypotension and postprandial hypotension, and this is another finding that you may have a symptom with the patient when he said that after he take his meal, he feels that he's dizzy and he has headache. He said that I take a good food, but actually I feel I'm not good. Sometimes this symptom has no definite relation with the doctor. And they found that just to make abdominal banding can help to solve this situation. So the important option we have first and second and third lifestyle modification. Lifestyle modification by increase the fluid intake, multiple small meals, because they found when you increase your meal, you are more susceptible for posture hypotension, wearing a compressive elastic stocking, leg exercise, and start to treating your body by elevating the head of the bed. Try to avoid the stimulation for the autonomic stressful condition, like try to avoid heating, excessive exercise like in marathon runner, abrupt standing, and large meal. A certain physical maneuver like strengthening and stretching of the lower limb is very important, and performing regular exercise, which can be done in lying down or recumbent position by using the exercise of upper limb. The management of underlying condition, usually treating the underlying condition, improving the treatment, the condition actually. And it is very important to make mix of the drug. They found that clonidine is the most effective drug can be used in this group of patients, and it can be combined with midodrine and prostigmine, as prostigmine and midodrine helping in posture hypotension, and clonidine controlling the hypertension. Despite of controlling the hypertension, it doesn't cause posture hypotension. And this is a very important task. The previous lecture, when they said that is beta blocker the same, all of us like beta blocker, which is very selective, because we prevent a lot of complication and side effect by this way. But in this situation, we need to take a non-selective form. And this is the regime and drug used, clonidine, losartan, labetalol, and in posture hypotension, pyridostigmine and midodrine. There is a lot of treatment future which containing immunomodulation. Some selected cases can be used, successful used therapies, including plasmapheresis and immunoglobulin, but all in the future. The first, second, and last, do good measurement and select the problem to take your task for management of the patient. Orthostatic hypotension, I found that there is a guideline for orthostatic hypotension. Actually, it is my first time to know it. And actually, they put, which we said, excessive fluid intake and avoid dehydration, which take a class 1 indication, and physical controlling, compressing, stocking, but as a drug, midodrine is taking. My take-home message, ladies and gentlemen, treatment of hypertension with orthostatic hypotension indeed present a challenging for the patient and for physician. Achieving perfect control of blood pressure is not realistic goal, and the treatment should be aimed primarily to improve the patient quality of life and decreasing their injury and decreasing in the organ damage. And thank you.
Thank you, Dr. Ghada, for this nice lecture. And actually, this subject is very important. كلنا عارفين نعالج الضغط العالي، لكن when you have a patient 170 over 100 millimeter mercury, you need to increase the medications more. And then he tells you أنا لما أقعد على السرير وأقوم أدوخ، ولما أكون بصلي وساجد وأقف أدوخ. It's really it's a problem الحقيقة. لكن I tried, I might hear our colleagues. I tried for these patients, instead of decreasing the medications, maybe if they have diuretics, I would shift to a non-diuretic antihypertensive. Abdominal binders and elastic socks. These are mechanical factors in the old age. I think they might be effective instead of decreasing blood pressure. I'd like to hear the opinion of Dr. Ghada and the audience, Professor Mohsen.
To me, this is correct. The problem is not escalate or reduce the antihypertensive, because when you do that, you ended by end organ damage. You should to search for maneuver to prevent orthostatic hypotension. You should to search for the medication the patient used, because actually all of our patients, they found that they take non-steroidal and they take nitrates. This is causing a posture hypotension, and this is causing hypertension.
Dr. Abghani.
Thank you, Professor Ghada. Sometimes the occurrence of orthostatic hypotension is secondary to wrong diagnosis. We do know that we have what is called pseudo-hypertension. Elderly patient with rigid brachial arteries, you have to go elevating his blood pressure till you have a very high number. This patient is not hypertensive. This patient has no target organ damage. This patient will complain of orthostatic hypotension once you describe antihypertensive treatment for him. So one of the causes of orthostatic hypotension is a clue for pseudo-hypertension or wrong diagnosis from the beginning.
Yes.
Is there any role, Dr. Ghada?
For that reason, dear sir, for that reason, when you found there is a high blood pressure in old patient and you couldn't find what is next, he has normal ECG, there is no LVH, the kidney is okay, there is no proteinuria, you should to think 2 times.
بس take care, it is atherosclerotic or rigid vessel wall في الاولد ايج زي ما قال الدكتور اللي هو بزودو هايبرتنشن، بس يعني لازم ما تدروش انتي هايبرتنسف بس عالج الفيزلز لانه لايبل لو اثيروسكليروسيس لايبل لسيرفوفاسكولار اند كارديوفاسكولار ستروك، رغم انه هو نون هايبرتنسف اكشولي بس الفيزلز وول stiff.
So the measurement of the blood pressure, and when you found a doubt, there is a rule for the central measurement of the blood pressure.
في نقطة مهمة بقى اللي هو الهايبوتنشن، بيجي لك العيان يقول لك ده انا رحت للدكتور اصل الضغط لاني الضغط واطي علق لي محلول. very bad. سامحيني معلش.
Take a lot of fluid is much better.
كده بيقيس له الضغط يقول له ضغط واطي.
Avoid dehydration is mandatory for the.
هو not dehydrated، هو ما عندوش vomiting ولا bleeding ولا اي حاجه، بس يقول لك ضغطك واطي.
If you wait till you feel thirst sensation, you are dehydrated. Sorry.
دكتورة غادة، وانت بتشوف الليتريتشر هل في seasonal variation for the orthostatic hypotension؟ وعايز اسال استاذنا الكبير
ايوه
استاذ الدكتور محسن ابراهيم، هل حضرتك بتضطر في الصيف انك تقلل الانتي هايبرتنسيف ميديكيشنز in some patients؟ في فرق بين الصيف والشتاء؟
فيسكوستي بالضبط.
انا ما بقللش الادويه بتاعت الهايبرتنشن في الصيف، انما طبعا احتمال في الصيف عشان خاطر السويتنج والفازو دايليتيشن
dehydration.
والهوت ويذر يبقى في تندنسي للورينج اوف ذا بلاد بريشر، ومعروف ان there is tendency في البلاد بريشر انه بيعلى في الشتاء عن في الصيف. انما طبعا يعني مش كل عيان زي الثاني، and you have to measure the blood pressure repeatedly and carefully before making any decision.
هي الليترتشر جاوبت على جزء من القصة دي وقالت رغم ان في seasonal variation in the blood pressure but you should to take the measurement to prevent orthostatic hypotension with maintaining the antihypertensive drug.
يبقى final comment I have here inspired from the lecture of Professor Al-Baghdadi is that the central blood pressure. Might these patients have a normal central blood pressure plus an abnormal peripheral? That's why when you reduce, he gets more hypertension and more posture. This is, I think this needs to be studied. لو حد يحب.
It needs further study and further screening for this group.
حضرتك عليه هل هنحتاج ambulatory blood pressure monitoring او ان احنا نقيس السنترال blood pressure علشان هل حضرتك مثلا ممكن تطلبي حاجه زي كده؟
السنترال بلاد بريشر مش هيحل لي لان هو المفروض ان انا بحلها بان انا اقيس السوباين بوزيشن واقيس الديبنج، فده يمكن حلها شويه الامبيلاتري بلاد بريشر. بس مشكله الامبيلاتري بلاد بريشر ان بيصحي العيان كتير، لكن النيو تكنولوجي اللي اعتقد انها هتطلع قريب هتحل الموضوع ده لانها تشتغل اكتر على الاوسيليشن.
نقدر نقول للعيان شويه تيبس، يعني مثلا افتر ميل بلاش الهيفي ميلز عشان تو افويد بوست براندل هايبرتنشن. ممكن التايمنج ان هو زي ما حضرتك قلتي ان هو يشرب ميه كتير. بالتالي اللي هي اللايف ستايل ده فيري افكتيف.
It's very important the lifestyle.
يمكن فعلا كمان قبل كمان ان انا اقلله الدوز بتاعت
Sure.
ثانك يو.
Thank you very much.